Welcome to the Healthcare and the ADA Inclusion of Persons with Disabilities webinar series. My name is Anne Deschamps from the Mid-Atlantic ADA Center, and with me is Jerry Davidson from the Pacific ADA Center, and we will be your moderators for today's session. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network, we are made up of 10 regional ADA centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional center by dialing 1-800-949-4232, or you can go to adata.org and find the center that serves the state you're calling from. Slide number 2, please. Okay, captioning. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the closed caption icon in the meeting control bar. This webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification to policy issues under the Americans with Disabilities Act of 1990. These webinars occur every other month on the fourth Thursday of every other month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 Pacific time. By being here, you are automatically on the list to receive notice for future webinars in this series. The notices go out 4 weeks before the next webinar and open for registration at that time. Slide number 3, please. Listening to the webinar. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial 1-669-900-9128 or 1-646-558-8656 and type in the webinar ID 878-5030-4643. And this is not a toll-free number. At the conclusion of today's presentation, there'll be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform. The speakers and Jerry and I will address them at the end of the session. So feel free to submit them as they come to mind during the presentation, and we will keep track of them. If for a reason related to your disability you cannot use the chat, please use the raise hand feature. Okay, Jerry, having said that, oh, here we go, submitting, technical assistance. Oh. Thanks, Gabe. Technical assistance. If you experience any technical difficulties during the webinar, send a private chat message to the host by typing in the chat window. Type your comments in the text box and enter. If using the keyboard, using Alt-H to access the chat box via the keyboard keys. Or email adaTech@adapacific.org or call 510-831-6714. Okay, I think that's it. Let me turn it over to you, Jerry.
Thank you, Anne, for doing the announcements. I am super excited about today's presentation. This is called Creating Inclusive Medical Environments. And I had the privilege of getting to see this presentation at the Pacific ADA Center's virtual conference this past year, and I loved it. And so I asked if the folks could come back and do it for this ADA National Network learning session. So I'm excited for you all to experience it through the lens of the Stanford Alliance for Disability Inclusion and Equity. Participants will learn practical approaches to creating more inclusive medical environments that benefit all patients and providers. This session emphasizes disability as a form of diversity that enriches healthcare through multiple perspectives and experiences. Today's speakers are Dr. Ken Sutha. He is a board-certified pediatric nephrologist and instructor at Lucille Packard Children's Hospital, Stanford, and Stanford University School of Medicine in Palo Alto, California, where he devotes his time to patient care, advocacy, and research. A two-time kidney transplant recipient himself, he serves as the co-chair of the Stanford Medicine Alliance for Disability Inclusion and Equity, and on the board of directors for the Disability and Medicine Mutual Mentorship Program. Also, we have with us Dr. Poulos, who is faculty in both radiology and gastroenterology and hepatology at Stanford University School of Medicine. In 2018, he founded the Stanford Medicine Alliance for Disability Inclusion and Equity, for which he serves as co-chair. In that role, he advocates for students and healthcare providers with disabilities and for health equity for disabled patients. He is faculty advisor to the Stanford medical students with disability and chronic illness and the MSDCI national organizations. Dr. Poulos has made significant contributions to the disability community when he started the Stanford Conference on Disability in Healthcare and Medicine, drawing over 18 participants from 52 countries. He is co-host of the Docs with Disabilities podcast and has spoken internationally about disability access in medicine. One of his proudest achievements is co-creating the Disability and Medicine Mutual Mentorship Program. In 2022, Dr. Poulos received the Stanford President's Award for Excellence Through Diversity. So obviously we have some very impressive folks speaking today, and I'm excited to absorb some of their knowledge. So I'm going to pass it over to you all.
Great. Thank you so much for that introduction, and thank you for having us here. As you heard, I'm a pediatric nephrologist at Stanford, and have had the great fortune of working with Dr. Poulos in being co-chair of the Stanford Medicine Alliance for Disability Inclusion and Equity. Dr. Poulos is running a little tiny bit late, but we've divided up the slides, and I'm happy and able to present his portions. There's a little bit of bio about him in there that we might skip over and have to come back to, but otherwise I will continue on. Next slide, please. We have no relevant disclosures. Next. As you probably saw from when you signed up, the goals of this presentation are to help to be able to recognize how ableism impacts healthcare, identifying common manifestations of ableism in healthcare settings and their impact on patient outcomes, and to think about ways that we can implement inclusive practices, including applying specific strategies to creating more accessible and equitable healthcare environments for both patients, but also providers with disabilities. And lastly, to advance representation by describing the unique value and perspective that healthcare professionals with disabilities bring to healthcare, patient care, and medical education. Next. Through this presentation, we'll start out by giving you a little bit of definition, level setting. I know this is all preaching to the choir, and this is background that you all already know, but some definitions about disabilities as related to the ADA, models of disability and disability identity. Get into a little bit more with background about disability and disability language and ableism, particularly how it impacts healthcare. And then highlighting health inequities faced by individuals with disabilities and things that we can do to improve the care for our disabled patients, and how including physicians and other healthcare workers with disabilities and supporting them will improve ultimately the care for our patients with disabilities. Next, please. So just to give you a little bit of background about myself and how I fit into this work and what brought me to this work. Next, please. We always like to start as physicians and healthcare people. We like to start our presentations with a patient scenario and a patient story. So this is not an uncommon scenario. As a kidney doctor myself, I often see patients like this. So this patient at 10 years old was found to have what's known as proteinuria, or abnormal protein in the urine. That's not supposed to be there. This is not that uncommon of a thing to see in kids that present with kidney disease, but oftentimes these kids will outgrow this illness, or they'll respond to routine treatment with medications, particularly one called steroids. Unfortunately for this patient, that wasn't the case, and they didn't have any response to the steroids and continued to have that abnormal protein. Ultimately, they got a biopsy, or so a small piece of the tissue of the kidney was taken, and diagnosis was made of something called FSGS, focal segmental glomerular sclerosis. That's basically a long way of saying that there was scarring of the kidney that indicated that there was damage. The doctors were able to control, but not completely stop the protein in the urine. And ultimately, this led to long-term damage to the kidney. And so over time, there was a slow decline in the GFR, or glomerular filtration rate, which is basically a measure of the function of the kidney. So to the point where the function of the kidney declined and was almost to something like 10 or 20% by the time this patient was graduating from college. Next, please. That patient ended up was actually me. And so by the time I was graduating, I knew that I would need to go on to dialysis or receive a transplant in order to survive. This here is a picture of me holding a cake that's shaped like a kidney just a couple of months before receiving a transplant. Next, please. So at the end of my second year of medical school, I received a kidney transplant from my dad. He was 60 years old at the time and in great health. Thanks to his transplant, I was able to return to medical school and to take my medical board exams on time with the rest of my classmates, and ultimately graduate with both my MD and my PhD. And so here we see a variety of pictures. One picture of me in bed immediately after my transplant holding a pillow shaped like a kidney. Next to that is a picture of me posing with my parents at the side of a pool. I was able to compete in things, because of my transplant, I was able to compete in things like the transplant games. Basically, it's like Olympics for people with transplants. Growing up with kidney disease, I never imagined that I could do athletic things. But after my transplant, I took up swimming because I recognized that I was at increased risk for things like diabetes and high blood pressure, and particularly medicines that I was on put me at risk for those. And not only was I able to start swimming, I was able to even win medals. Next to that, I was also able to go to camp with kids with different kinds of diseases, including kidney disease and with transplants. And there's a picture of me covered in paint next to a friend of mine. Ultimately, I graduated from medical school, and there's a picture of me at my graduation with my classmates when I graduated with my MD and my PhD. And I then entered training to become a pediatrician and ultimately a pediatric nephrologist. And there's a picture of me wearing scrubs, hula hooping, and a picture of me holding up a sign saying "Register to Save Lives." Through my experience, I learned that by sharing my experience and the things that I went through as a transplanted kidney patient, I was able to help other people as well, and particularly by increasing awareness about organ donation and the power of transplant. Through all of this, though, I didn't really have a very strong conception of what it meant to be disabled and how my experience with kidney disease and chronic illness fit under the greater umbrella of disability. Next slide. But transplant is a treatment and not a cure, and it comes with many of its own issues as well, and that was the case for me as well. I struggled particularly with infections because of the medications that I needed to take to prevent me from rejecting my transplanted kidney. That put me at risk for different types of infections. Infections that would, in otherwise healthy people, would lead to things like mono or routine infections that people would normally, the immune system would fight off, can sometimes in transplant recipients with suppressed immune systems, sometimes even lead to certain types of cancer. I particularly was having issues with a virus called EBV, Epstein-Barr virus. And so because of that, they had to make adjustments to my immunosuppression, which ultimately opened up the door to rejection. And I was ping-ponging back and forth between infection and rejection. About a decade after my transplant, because of the rejection, I was again facing the need to go onto dialysis or to receive another transplant. Particularly, I also dealt with side effects from the medications I took. I was at risk for developing high levels of potassium, which is an electrolyte that's regulated by the kidney. and that can sometimes lead to abnormalities in the heart. Here we see a picture of an EKG tracing with a characteristic peak, what we call peak T wave, which is a sign of high potassium levels, which can sometimes lead to abnormalities in the rhythm of the heart, and sometimes even death. And so it can be very dangerous. And this is a EKG that was for me myself. And so because of that, I ultimately needed to go on to dialysis. I was fortunate that I was able to do a form of dialysis that I could do at home, called peritoneal dialysis. That allowed me to continue working full time and ultimately to do my training here at Stanford in pediatric nephrology. And so at the same time that I was moving here to become a pediatric nephrologist, I was also receiving dialysis for 8 to 10 hours overnight as well. Next, please. And through that, I was very privileged that because I was able to do this, I was still able to continue working full time, do things like traveling. And so we see pictures here of me at work with one of my colleagues, actually my own nephrologist, and a giant kidney mascot. There's also a picture of me sitting next to my dialysis machine. That was basically my lifeline, and as well as a picture of a wall like full of boxes that were my dialysis supplies. Again, I was very privileged in that I had the resources to be able to do this, and had the space to be able to accommodate all of the dialysis supplies that I needed to have in my home. Not all patients that are on dialysis have this luxury and this flexibility, with many having to go to in-center dialysis 3 times a week for several hours. And as you can imagine, that is very disruptive to one's normal daily schedule and can often interrupt one's ability to work full time. Next, please. Fortunately, after about 2 years on dialysis, I received a second transplant, this time from a deceased donor. Here's a picture of me the morning after receiving my transplant. They got me up and walking almost immediately right away to help me with my recovery. Here in my gown using a walker. I was able to go and decorate the Rose Parade float for the Donate Life organization to raise awareness for organ donation. Then there's a picture of me with my dad as we're placing a rose onto a portion of the float. And then as well, a picture of me wearing a Giants uniform when I got a chance to be a ball dude at a Giants baseball game here in San Francisco. Again, raising awareness about organ donation. Next, please. And as I mentioned, through all this, I learned that by sharing my experiences, I was gaining a lot of power and learning that the experiences that I had could have an impact on others. And here we see a variety of different logos for organizations that I was able to get involved with after my transplant. The American Society of Nephrology, the American Society for Transplantation, American Kidney Fund, as an example of a couple of them. And most importantly, the Stanford Medicine Alliance for Disability, Inclusion, and Equity, which we'll hear a little bit more about later on in this presentation. Next. And again, in my work, in addition to working with SMADIE, the Stanford Medicine Alliance for Disability, Inclusion, and Equity, and as a pediatric nephrologist taking care of patients, a lot of my time is actually spent doing research in the lab, trying to come up with treatments for kidney disease. Next, please. But really what motivates me is my patients. So here we see pictures of 2 patients that I've had the immense pleasure of taking care of since they were born. They required dialysis from an early age, but then ultimately received transplants. And because of that, they've been able to continue to grow and thrive. But as I mentioned, it's not always an easy road, and there's still things that come along with transplant. As it's a treatment and not a cure, as a lifelong condition that they are dealing with. Next, please. And now I'll transition over to Pete, who will give a background about himself.
Hi, everyone. I'm Pete Poulos. I'm a clinical professor of radiology at Stanford Medicine and also the founder and co-chair of SMADIE with Ken. And I'm a middle-aged white guy with brown hair wearing a blue jacket. Next slide. This is a photo of me in 2002. I'm in my spandex bike uniform riding up a hill in San Francisco. I started cycling to work in my medicine residency and because I wanted to get in shape. I was feeling after my intern year um, I just gained a bunch of weight and was very out of shape and wanted a way to burn off some stress and get healthy. And so I started riding my bike and discovered I loved it so much that I started racing. And so that's like a racing uniform that I was wearing at the time. So typical type A going from 0 to 100 very quickly. Keep going. This picture was taken of me of January 4th, 2003. I'm with my mentor, Dr. Cello there, who's wearing a Hawaiian shirt. And we're hanging out on his deck in Tiburon, celebrating the new year. And I got, actually, I'm drinking a Diet Coke there in the picture because I was on call. And I got called in that day for somebody who was vomiting blood and part of sorry, I didn't even say that I had started a fellowship in gastroenterology in July of 2002. And so this is like 6 months into my fellowship. And I got called into the hospital for this person who was having upper GI bleeding. And I was able to do a procedure on him called endoscopy to go down the esophagus and find where the bleeding was and then treat the bleeding with rubber bands. And it was a very difficult procedure to do. And I had tried on several occasions before that day and ultimately wasn't able to complete the procedure by myself. But this day I was, and I was very proud and happy that my endoscopy skills were getting better. And so I went home that night, came back to the hospital in the morning. We had a very light service with only a couple of patients. And so I left the hospital very early that day and decided to go out for a bike ride. And I was planning on just like going out for an hour and coming back and hanging out at home. Um, but unfortunately, I had an accident on the way and I ended up falling down some stairs and getting paralyzed from the neck down. And so this next picture here, if you can click ahead, is a picture of me in the ICU at San Francisco General Hospital. This is a hospital um, where I worked and took care of patients for several years. And unfortunately, I couldn't move anything from, like I said, from my neck down. And my doctors were very circumspect or guarded with their prognosis. Nobody knew if I was going to be able to move anything or if I was going to be left paralyzed from the neck down. It's obviously like very stressful and difficult time. So after a week in the ICU there, I got transferred to Santa Clara Valley Medical Center. I was lucky that we had a spinal cord injury center less than an hour away from my house. Next slide. And this is a picture of me at Santa Clara Valley. So I was eventually able to get out of bed and sit down in a power chair, still unable to move my arms or my legs. And I was driving the power chair with that chin drive there. And I've got a cookie bouquet on my lap, which is probably the reason I'm smiling. That was like the one nice thing about being in the hospital is eating all the goodies that people would bring you. Um, I was obviously, I don't know. I didn't want to really get out of bed. I was quite depressed, and sad and traumatized by this whole thing. But the the nurses and doctors encouraged me to hope for the best, but prepare for the worst. And so explained to me that, getting out of bed is the first step. And even though you can't use your arms or legs, you can still direct your movements and actually felt a lot better being able to move around the hospital. Next slide. Fortunately for me, I started to get movement back in my legs. And here I am in a manual wheelchair, sort of crab walking around the hospital, trying to get those legs working again. Next slide. And then my arms started coming back a little bit after that, and here I am eating some hospital French toast I have my arm in a sling, and there's a device on my hand to hold a bent fork, and there's a plate guard on the plate, and then there's a non-stick thing underneath the plate. So there's a lot going on in that photo to help me get to my hospital French toast. Keep going. A little bit later on in my stay, which was ultimately about 2.5 months in the hospital, I was able to get up into the parallel bars, and I've got full leg braces on there and being helped out by 2 physical therapists who are trying to, get my legs moving. And I was really relieved to be able to stand up again, even though taking even one step was like very difficult. And so luckily, over time, things just kept on coming back. And next picture. This is sort of where I ended up about 6 months after my accident, and I was able to walk here with a forearm crutch and with some leg braces. I'm looking down at the ground because I can't really feel my legs very well, and I need to be able to see to balance. And then my physical therapist right there is holding on to me. And so, um, it was quite a big recovery, an excellent recovery, actually, considering where I had started. But my arms were still not moving very well at all, and my walking really never did return to normal. It's like still very slow and not that safe. And so, keep going. So a part of the time I use a wheelchair. I sort of switch back and forth. This is a picture of me in my white coat back in my little apartment in San Francisco after getting discharged from the hospital. And I have a number one, making the number one sign with my hand, like very proud that I was just alive. And going back to clinic, I was very excited to get back to work and to be back with my colleagues and doing what I love to do. And things were really different for me as far as seeing patients when I found myself, having a lot more empathy and understanding. I found myself asking better questions, not just about, their symptoms, but also about their daily life and their frustrations. But on the flip side, it was also very difficult, and that I couldn't really do a physical exam by myself. I needed somebody to help me with that. I couldn't really type anymore. I couldn't hold the scopes or come close to doing any sort of procedures. And so I really felt like distressed about what I was going to do with the rest of my life. Didn't really want to stay in GI anymore and need all of this help. And I felt like I would just be trapped in academics as like a GI doctor who didn't do any procedures. And I wanted independence. I wanted to practice independently without any limitations and to do a job where I could be like I said, just um, not have any limitations placed on me. And so I decided actually to switch into radiology. And so, next slide. So this is me in my first year of my radiology residency, rocking the CRT monitors, reading chest x-rays. And I really, it was a bit of a tough transition at first, but ultimately, I think was a good decision and one that I'm still very happy with now, 21 years later after starting. Next slide. Eventually, I got a van from the California Department of Rehabilitation so I could drive myself to work. And there I am in my wheelchair coming out onto the lift. And then next slide. In 2007, I discovered the Segway as another way of getting around. And this is a picture of me in my white coat riding my Segway. There's a little disabled placard on the front of the Segway, which I had to put on there because like people didn't understand that I was disabled and riding this as like a mobility device. They thought I was just some rich white Silicon Valley dude cruising, not wanting to walk and cruising around on his Segway. So the one I have on now is even bigger. Like you can't miss it. There's stickers on the back. Um, People still yell at me about it getting off the Segway and calling me lazy, but uh, you know, whatever. It is what it is. So that's kind of how I'm getting around these days with between the crutches, the Segway, the wheelchair. I have another wheelchair. My whole garage is just filled with like assistive devices of different flavors. So yeah, this is all I finished my residency and in fellowship in 2009. I'm actually ended up doing GI radiology. So same diseases as I was treating as a gastroenterologist, but now from the imaging side of things. Next slide. And so over the next 10 years or so, I did a lot of teaching. I did administrative work for the residency program. And then basically in around 2016, after I started doing the residency program, started looking around for other things to do. Next slide. And around this time, diversity initiatives were popping up all around campus. And on the left here, we have this infographic from my radiology department diversity initiative. And they have like silhouettes of 6 different people, and 2 of them actually have visible disabilities. One person using a wheelchair and another using a walker. I thought that that was really a great representation. But when I looked on the list of people who were on the committee, I couldn't really be sure that any of them actually had a disability or understood disability. And so I volunteered to be on that committee. And that was my first foray into the diversity space. The infographic on the right is another diversity infographic that shows diversity of race and gender and ethnicity and religion, but doesn't display anything about disability. And this is kind of how I encountered the space when I first entered, that there was like very good representation from most groups, but not in people really weren't thinking about disability at all. And so, for example, we had what they call the diversity cabinet on campus for years, which brings together people from all different branches of the medical center and the university. And they had representation from all groups, but didn't really have anything about disability. Next slide. And so, yeah, in late 2018, as part of my diversity work in the Faculty Senate, we created a group which I initially called the Stanford Medicine Abilities Coalition, SMAC, mostly because I loved saying SMAC and I thought it was a great acronym. We eventually would rename it the Stanford Medicine Alliance for Disability Inclusion and Equity, or SMADIE, which I like less, but embraces the term disability and makes it more clear who we are, what we represent, and to show disability pride. And there's Ken sitting in the front row there with his baseball hat, who I didn't know at the time, but then who would become very shortly after my co-pilot. And I couldn't really do any of this work without him. And next slide. And
Yeah, so now that you have some context about who we are, I'll give you a little bit of idea about how our ideas about disability and ableism have continued to grow and evolve, as Pete mentioned, even reflected in the changing of the name of our organization. I'll just give a little bit of a background about some things related to disability. This will be, of course, be very known to all of you. Next. Of course, you are all very familiar with the definition of disability under the ADA as a physical or mental impairment that substantially limits one or more major life activity. Next. Importantly, though, in addition to this definition, there are over 50 definitions under federal law, from SSI to Social Security and Disability, Medicare, etc. And even outside of federal law, other types of disability as how it's conceived of in other different contexts. Next, please. An important thing from that ADA definition is that the idea of defining what a reasonable accommodation is. First, we have to think about what qualifying conditions there might be that, especially us as medical providers, how that interacts with that definition and with people's experience. And accommodations have to not present an undue burden, and also not change the essential job function of the job. Importantly, though, something that we've encountered, especially as we are trying to raise awareness about disability within the healthcare setting, is that accommodations are rights, not privileges. And that the idea of that there isn't something about providing these accommodations to people, there's no idea of fairness that's applying to the ADA here. So because we're providing, for example, extra time for people, that doesn't mean that we need to provide it to everybody who may not require that as an accommodation. Next, please. It's been important for us to recognize and to spread within our healthcare setting that disabled and disability isn't a bad word. And we have to think about disability as a fundamental part of human diversity and the human experience. That said, different people may experience the same conditions, qualifying conditions, underlying disabilities completely differently, and therefore may or may not identify as disabled. As I mentioned during my story, it wasn't until much later in the process that I began to understand the commonalities that my experience growing up with chronic kidney disease and ultimately having a transplant and being on dialysis had with people with different kinds of disabilities. Through the work of SMADIE, being involved with Pete and learning from him, I've begun to and was able to embrace the idea of disability identity and disability pride in community. Understanding how our lived experiences as people with disabilities impacts the way that we interact with the world, how the world interacts with us, and the positive things that come from our experiences in terms of our community and our shared experiences. One thing that's, I'm sure you're aware, can be very confusing for many people, particularly within the healthcare field, is the distinction between disability identity and the idea of when it's used with relation to leave and benefits and in a medical context. Next, please. But as you're aware, disability affects a large proportion of people within the United States and globally, according to this diagram from the CDC, 1 in 4 adults in the United States having some type of disability. And that can include both people who identify as having a disability and those that have conditions that qualify them as having a disability, as you are aware. Next, please. As I mentioned, disability itself is diverse as well and can encompass things from mobility disabilities and sensory disabilities, but also non-apparent disabilities, including learning disabilities, autism spectrum, chronic health conditions, etc. And it wasn't until I was working with Pete and understanding more about the diversity of disability to really see exactly how I fit under this umbrella and how my experiences really shared much in common with other people with disability, and the collective power that we have by embracing disability identity and working together. Next, please. As you're also probably aware, individual experiences with disability are also very diverse as well. And a lot of this has to do with intersectional identities that people may carry. We know that rates of disability are different across different ethnic groups, with higher rates of disability amongst American, Indian, Alaska Native, and Black populations as compared to white individuals and Hispanic and Asian populations. And because of this and these intersectional identities, this may also impact resources that people may have access to. So for example, again, from my experience being on dialysis, because I had the privilege of being able to do peritoneal dialysis at home, I was able to continue working full time. whereas somebody else with the exact same underlying chronic kidney disease and kidney failure requiring dialysis, if they didn't have the resources to be able to do dialysis at home, they may have to do in-center dialysis, which requires going to a dialysis center multiple times a week for several hours, which may preclude them from working. Similarly, because of all the supplies that I needed, that took up a lot of space in my home. And so being able to afford housing that could accommodate that is no trivial matter, especially here in the Bay Area where housing prices are through the roof. Next, please. And again, many different types of conditions may qualify as towards a disability. And depending on how people experience these conditions, they may or may not lead to limitation and therefore equal disability. Different people experience these same conditions completely differently, and it depends on context, environment, and intersectional identities. Additionally, disability isn't always static, and it may wax or wane or be progressive. So even though my kidney failure has been the same for many years now, my access to that impact on me has been very different when I was on dialysis versus now when I have a well-functioning transplant. But there are other things that come along with it as well, the immunosuppression and how that might impact my ability to go out in society, particularly as we saw during the COVID-19 pandemic. On the left-hand side, we see a diagram with multiple different types of conditions that may or may not lead to limitations and therefore disability. And this, of course, is not an exhaustive list. Next, please. Transition here to Pete.
So I'm going to discuss models of disability. A model of disability is a way of conceptualizing disability. And there are two main models of disability that people talk about. There are many others, but the medical model and the social model are two that are worth discussing, and they're best understood by comparing and contrasting to one another. So this slide says the medical model of disability, and there's a picture of a disabled woman with a circle around her, and there's the word problem pointing at the person. And so the underlying assumption in the medical model is that the person with the disability has the problem. And so it's very focused. This is more prominent in medicine, of course, since it's the medical model, but we're really focused on impairments and disease. It's very focused also on cure and alleviation of perceived suffering. It doesn't really provide for assisted decision making or any real decision making on the part of the person with the disability. There's an element of charity that goes along with it. And the idea that the disabled person must adjust to fit into society. Society was not made for people with disabilities. And even better, if the person can overcome or rise above their disability. These are some of the themes with the medical model. Next. This slide says the social model of disability, and there's a diagram of a man with an amputation standing in the middle of a circle, and the arrows are pointing away from him to the word barriers. And so this diagram represents that it's not the person with the disability that has the problem, it's the barriers within society that disable the person. And so this model recognizes that disabled people are quote unquote normal, that we're a part of the normal spectrum of humanity and we deserve equal rights. It's focused on autonomy, choice, free and informed consent, and the idea that the disabled person should be supported by society and that the community should adjust, not the individual. And so, both of these models are sort of extreme in their conception, but they're best understood by comparing and contrasting to one another. And there are models that account for both aspects. Like there's a biopsychosocial model, for example, that is more complex. Keep going. So you may ask, like, if you're not disabled, how does this affect me? And so it's important to recognize how ableism fits in as a form of oppression. And there's a Venn diagram on the left showing ableism interacting or overlapping with racism, sexism, and anti-LGBTQ, and many other isms, actually. And so I don't want to conflate ableism with these other isms, but it's interesting to know how ableism has been used to justify other forms of discrimination. So, for example, declaring that certain subgroups of people, should not have autonomy, that need to be taken care of. That, for example, women shouldn't have the right to vote because they don't have the ability to have rational thought. Things that are the excuses that have been made over time to declare certain members of our society as defective and not capable of full civic participation. And just like other forms of oppression, there are different levels of ableism. We have structural barriers, institutional, interpersonal, and even internalized ableism. Next slide. This is the working definition of ableism by Talia Lewis. And I'll just read this out loud. Ableism is a system of assigning value to people's bodies and minds based on societally constructed ideas of normalcy, productivity, desirability, intelligence, excellence, and fitness. These constructed ideas are deeply rooted in eugenics, anti-Blackness, misogyny, colonialism, imperialism, and capitalism. And this systemic oppression leads to people in society determining people's value based on their culture, age, language, appearance, religion, birth or living place, health, wellness, and or their ability to satisfactorily reproduce, quote unquote, excel and behave. And importantly, you do not have to be disabled to experience ableism. There's so much to unpack in this very complex definition, but needless to say, this runs deep in our society. Next. Healthcare providers are less than immune to ideas of ableism. And this was an article from 2021 written by Lisa Iazzoni from Harvard. She studied a bunch of different physicians in different specialties. And, 80% of the respondents agreed that understanding patients with disabilities was valuable, but only 40% felt that they were confident that they could provide the same quality of care. Barely more than half of them would welcome patients with disabilities in their practice. Very few of them thought that patients with disabilities were treated unfairly in the system. And 82% believe that those with significant disabilities have a worse quality of life. Keep going. So although most physicians did not strongly agree that patients with disability are treated unfairly, less than half of them felt very confident they could provide the same quality of care. And like I said, they really weren't welcoming patients with disabilities in their practice. So there's a real disconnect there. Next. Next. So there's also something known as the disability paradox, and this was a study from the 90s that was very illustrative, that they surveyed emergency medicine providers about their beliefs about quality of life of people with disabilities and compared those answers to results of studies of actual people with severe disabilities and how they felt about their quality of life. And so given a scenario of having a severe spinal cord injury, only 18% of the providers imagined that they would be glad to be alive after that, compared to 92% of those living with spinal cord injury who were glad to be alive. The imagined quality of life and outcomes were much more negative, and even more distressing, 40% believe that resuscitation efforts in the field are too aggressive. So there's a real disconnect here between what providers perceive our lives to be and how we perceive our lives to be. And, definitely after my injury, I was very upset and sad. But over time, people just adjust to their new circumstances and basically return to their baseline levels of happiness. We're very resilient as human beings. Why do we have such a negative view of disability as providers? Probably has something to do with the fact that we see people at their worst in the hospital, very ill and not thriving and working and living out in the community, living their lives. We have very little education about disability culture, CRIP culture, and what people with disabilities are actually capable of. Next. And if you look at the numbers about how our patients with disabilities are doing when it comes to healthcare, these diagrams are from the CDC. 1 in 3 people with disabilities do not have a usual healthcare provider. 1 in 3 have an unmet healthcare need because of cost in the past year. And 1 in 4 did not have a routine checkup in the past year. And these are worse than patients without disabilities. Keep going. And looking at social determinants of health, adults with disabilities are more likely to be obese, to smoke, to have premature heart disease, and to also have diabetes. And so we're not really doing great for our patients with disabilities. Next. Unfortunately, the ADA is quite weak in this regard when it comes to healthcare. It requires equitable care, but very little is actually required. If you look at the law, you have to have accessible parking lot with disabled spaces. External entrances have to have accessible doors, which they often don't. Restrooms, again, and a disabled access restroom is also required, which also is like sometimes not included. So even these minimal things are sometimes not met. What isn't required under the ADA is furnishings or equipment like accessible weight scales, exam tables, and chairs that can accommodate people with disabilities, and then diagnostic imaging equipment. Keep going. So fortunately, in May of 2024, the rules, the final rules of the Section 504 of the Rehab Act of 1973 were put in place. Section 504 prohibits discrimination in programs and activities that receive federal funding. And so this added so many rules and protections and regulations to ensure patients with disabilities have equal access to healthcare, including web and mobile accessibility, accessible medical equipment, integration across other rules, and improves consistency with the ADA. So again, these rules are in place. 2024 was a great year for people with disabilities in healthcare, but we'll see if these rules get enforced or are being enforced in our current climate. Next one. Also, recently, people with disabilities were finally designated as a population with health disparities when we used to be able to say health disparities. So this also will hopefully improve access to healthcare and improve health outcomes for all people with disabilities. Keep going.
At this point, I would like to talk a little bit about the impact of disability and chronic illness on the healthcare workforce and the experiences of ableism that are kind of baked into the way that disabled healthcare workers are treated. Next, please. As we heard before, we know that people with disabilities are the largest minority in America, comprising about 26%, about 1 in 4. Next, please. Yet they're completely underrepresented in medical schools, with only 8% identifying as having a disability. This might be a little bit lower than the true number if we're counting all the people that may not identify as having a disability but have qualifying condition. But we see that there is an underrepresentation. Next, please. Oh, I think it went backwards. But yes, this continues into residency program training, still remaining about 8%. Next, please. And it's even more so amongst practicing physicians, down to just 3% in one study. Next, please. Why might this be? Well, we know that there's a culture of strength in medicine that kind of underlies a lot of the way that people conceive of their self-identity. And this is especially true in residency programs. During residency, doctors are expected to tolerate suffering, the likes of which other professions don't ever have to deal with. And they're expected to work long shifts without complaining, trained not to ask for anything, to take care of themselves, not take time off for things like important medical visits, or even for bathroom breaks. We're just expected to be fast and efficient and not given enough time for self-care. And people, they even will celebrate this and brag about it, saying things like, I only slept 5 hours last night, or I've only had 1 day off in the last few weeks. It's not uncommon to hear that. And instead of being something that is admired, this should sound an alarm for people. Thankfully, the culture is starting to shift a little bit as institutions are starting to recognize the importance of wellness. But even with that shift, we're seeing that there is a reliance on individual resilience as opposed to systemic changes to support people to allow them to take care of themselves. Next, please.
There are many barriers to disability inclusion in medicine. Some of these barriers are cultural and others are structural. And I've taken this from the AAMC report written by Lisa Meeks in 2018. On the cultural side, there are just lots of stereotypes and stigma around what disabled people can and cannot do. The idea of a clinical culture refers to the way people speak about disability or specific diagnoses. For example, if you're teaching a class about inflammatory bowel disease and describe it as a devastating condition with a poor quality of life, somebody in the audience that has IBD may take issue with that, but feels unsafe to disclose or to discuss. But our professors assume that there is nobody disabled or chronically ill in the class. It's more of a medical model idea, not a social model. Patients are often referred to just by their diagnosis. There's a real lack of holistic understanding of the patients. Your peers may have negative attitudes towards you if you disclose your disability. And people have very narrow views of what those with disabilities can accomplish and are often counseled out of specialties that are perceived to be more physically demanding. On the structural side, many medical schools do not have disability service providers that are familiar with clinical accommodations. Policies and procedures may be unclear or lacking or absent. People may not know where to go. There's lack of access to other meaningful accommodations. Technical standards may be hard to find and provide maybe hard to find, and then may also be discriminatory, and they may not reflect current technology or other developments in practice. And there's also a lack of access to healthcare and wellness supports to help students and other doctors with disabilities. Keep going. This is an article written by one of our proteges, Dr. Suchi Rastogi, who is a medical student at Stanford, currently on leave. And she wrote about her experience on the wards after becoming disabled. And she went to our Office of Accessible Education, which at that point was still located on the main campus, not in the medical school like it is now. She found that the help there was very unfamiliar with the medical environment, that her accommodations were like very unclear. They were often challenged by her supervisors, which put her in a very uncomfortable situation to defend both her disability and her accommodations. They were basically ignored. She was supposed to be able to sit down and take breaks, and but the team would just expect her to climb stairs and she would take the elevator sometimes or try to keep up and just fall behind on rounds and miss out on patient presentations and examinations. And when she went home early, which was in keeping with her working hours restrictions, she was publicly shamed for leaving. And this was like obviously an experience that was quite traumatic for Suchi, and she felt compelled to write about it to inform people of ways that the system could be improved, and also to sound the alarm that this is not okay. Keep going. Dr. Lisa Meeks is doing a lot of work in looking at physicians with disabilities and their experience. Um, this is an article here about mistreatment of physicians with disabilities. And, if you go down this list of types of mistreatment, offensive sexist remarks, racially or ethnically offensive remarks, uh, remarks about sexual orientation, to disability, to um, uh, personal beliefs. These are all like higher in physicians with disabilities than those without. And they're also higher. It's not just the coworkers who can be mistreating the physicians. Even patients may discriminate against physicians with disabilities. They're also more likely to be threatened with physical harm and actually to be physically harmed themselves, either by a coworker or by a patient. And also there's some overlap here with unwanted sexual advances. And this is obviously quite distressing. Keep going. There's also a higher rate of burnout in physicians with disabilities. There's a significantly higher likelihood of depersonalization, which is one of the core components of being burned out. They actually didn't show a statistically different rates of burnout between those with disabilities and non-disabled physicians. In fact, there was a slight less likely to be burned out, but this was not statistically significant. But in this one component of burnout, the most important component, again, we had like a higher likelihood. And this has been, borne out by what I've seen talking to disabled physicians. Next. So now we're going to talk about creative inclusion. Next. So this is a pyramid illustrating the different approaches to disability inclusion that we see in our environment. The base of the pyramid, or the lowest level of disability inclusion, is compliance. And this is the law as the ceiling. The most we're going to do is the minimum. We're not going to go any farther. We'll comply with the law to avoid lawsuits. It's very risk avert. People are careful not to overtly discriminate, but they're very much protecting the institution. The locus is on the individual and the medical model, and accommodations are closely guarded. And there's really an adversarial relationship between the institution and the person with the disability. And I would say that most institutions, most medical institutions are at this baseline level. Next is the spirit of the law. This is a more liberal interpretation, looking at the law as the floor rather than the ceiling, takes a more nuanced view, looks at people with disabilities as an opportunity for practice or environmental improvements. It's not focused on compliance as much as equal access, and may provide streamlined accommodations and include people with disabilities in their diversity efforts. And I would say a minimum, very few institutions are at this level. And next is the transformative approach. And we see glimpses of this, people talk about it, but it really doesn't exist anywhere yet. This would be a model focused on social justice, honoring disability and differences. It would be anti-ableist and embrace the benefits of universal design. Next slide. My Stanford radiology experience, I would describe as like a very positive one. This is a picture of me with my hospital volunteers. So the hospital provides volunteers to help me as personal assistants to get me from place to place through this very inaccessible hospital. They help me with drinks and coffee and Segway and all of these other things so I can concentrate on my job. The picture of the woman there, that's my program director, Dr. Desser, who was very open-minded and flexible. She understood exactly what latitude she had within the residency to get me the experience I needed, but to avoid over fatiguing me. For example, she allowed me to take call in a different way that was more frequent, but for less hours. She knew that I didn't have to do procedures to get board certified, and so she had me double covered on procedural rotations. And this is a picture of me with my residency classmates who are also like very instrumental in getting me through. Next. And there's this idea of the upward spiral or positive informed information about people with disabilities where, when a student or when somebody in medicine interacts with a colleague, a student, or another professional with a disability, sort of opens their eyes about disability and reduces stereotypes and assumptions about people with disabilities and what they can accomplish. And we hypothesize that that can translate into more informed patient care and hopefully reduce healthcare disparities caused by stereotype. And this is one of the things that we talk about as a benefit of including people with disabilities in the medical field. Next. So disabled provider patients live on both sides of the stethoscope. You can keep on pressing here to fill out the slide. We have a unique perspective on life and health. We are the ones working for access and inclusive care for everybody, and we are here to role model and represent what's possible. And because of what we've been through, we have grit, and having disabled people around in our system improves conditions for everybody. And these are just some of the photos of our friends and colleagues who have been working in this space to improve conditions for everybody. Next slide.
All of these things together motivate the work that we do with SMADIE, the Stanford Medicine Alliance for Disability Inclusion and Equity, or as you heard Pete said, formerly known as SMAC. Here we see some pictures from one of the early SMAC events and a more recent photo exhibit that we had by Rick Godotti with Positive Exposure, highlighting healthcare providers with different types of disabilities. Next, please. And really, we work at this intersection trying to affect change in health equity for our patients with disabilities, while also championing disability inclusion for those of us with disabilities within the healthcare workforce. Next. And we do this by focusing on 6 specific mission functions: research, advocacy, community, education, health equity, and mentorship. Next. In doing this work, we've partnered with a variety of different organizations to fulfill each of these missions. As we heard a little bit about in Pete's bio, one of the core things that we have done has been developing the Stanford Conference for Disability in Healthcare and Medicine, held each April. On the slide, there's a QR code to our website, which I'm also putting the link in the chat. On our website, you can find the materials from all of our previous conferences the last several years, YouTube videos of the presentations, and encourage you to be on the lookout for future, our conference coming up in April that's coming here and joining us. Additionally, we've partnered with a variety of other organizations, including the Medical Students with Disability and Chronic Illness, and the Docs with Disabilities Initiative, of which Pete is co-host of their podcast. And we also, with Dr. Suchita Rastogi, who you heard about a little bit earlier, founded the Disability in Medicine Mutual Mentorship Program. This is a program meant to support trainees and learners at all different stages. We adopt a mutual mentorship program because or mentorship model, because although you may have different people in the hierarchy of medical training, those people may be at completely different stages of their journey with disability and their disability identity. So that is, a pre-medical student may have lived with their disability all their life, whereas a senior attending may have just acquired a disability and is just learning to accept and understand what disability is. And so there can be bi-directional mentorship that's going on across those different levels and different life experiences. Next, please. So some steps that we can take and you can take in terms of increasing access for our patients with disability and those with disabilities within the healthcare workforce. Next. As clinicians, we have responsibilities to our patients with disabilities. We must develop disability humility and understanding disability identity. We have to learn how to communicate better with our patients with disability and about our patients with disabilities. And we must recognize the authority of patients and people with disabilities as experts in their own lives and elevate the voices of those communities and those lived experiences. Next. Additionally, in order to support both our patients and our learners and healthcare providers with disabilities, we have to consider structural changes that need to be made in order to provide meaningful access. We need to be able to designate and provide resources for disability service providers who are knowledgeable about medical education. As Pete mentioned, with Suchita's experience, when she was in a clinical environment, she was working with disability service providers who didn't know what the clinical environment was like, and so therefore didn't have a clear understanding of the different kinds of accommodations that might be needed. Next, we have to publicize clear and accessible policies and processes about accommodation and disability. We have to provide access to appropriate accommodations, both in clinical and learning environments. And for our learners, we need to review and revise the technical standards in light of current promising practices, and understanding what actually are the required things that we need people to be able to do in order to become competent healthcare providers. And that may not be as limited as has previously been thought. Additionally, and lastly, we need to normalize help-seeking behaviors for those with disabilities and everyone in order to facilitate access to wellness services. Next. And in order to continue to foster this welcoming, inclusive environment, We need to regularly assess the policies that we have, the processes, services, and the physical space in which our medical education and our clinical service is occurring. We have to provide ongoing professional development for faculty and staff so that they can learn to integrate best practices for disability inclusion, not only for our learners, but for our patients. And we need to be able to make sure that they're using accessible and respectful language in our curricula, in our pedagogy, and in our interactions with our patients. We must also integrate disability into diversity and inclusion efforts and initiatives, and make information about disability services and accommodations easily accessible. We found that many people with disabilities don't know where to turn. And so one of the things that we've been doing at SMADIE has been trying to streamline that process and making sure that everybody knows where these things are, whether or not they need access to these accommodations or not. We also must review our recruitment and hiring practices, and lastly, take universal design approaches into both our physical space and our learner activities and experiences. Next. I think Pete may be able to speak a little bit more about the work that's being done by the Docs with Disabilities Initiative.
And I just want to chime in really quick because we want to make sure we have time for questions. So if we can give a quick synopsis of this so we can make sure folks get their questions answered.
Absolutely. This is just a quick plug for Docs with Disabilities initiative that has many different subgroups and initiatives and projects that are being undertaken. And so I'd encourage those of you who are interested in this to visit their website. Next. So in conclusion, disability is diverse and disability is diverse and disability needs to be a part of diversity. It's not a bad word. It's more than just SSDI, leave, and benefits. Disability, importantly, does not equal inability. We encourage people to say the word. Remember that disability identity is personal, and one may or may not self-identify, and one has the right to use their own language about their disability. And that one's experience with disability depends on the context, the environment, and all of their intersectional identities. And when it comes to whether it's our colleagues or our patients, believe people's lived experience and act with cultural humility. Next. Thank you. That's a picture of me and Ken with our SMADIE jackets. And I think with that, we will open it up for questions.
Great. Thank you both so much. I think I speak for both Jerry and myself as people outside of the medical profession, educating people about the Americans with Disabilities Act and disability inclusion, that it's so refreshing to hear from somebody inside the medical profession who's doing the same thing. So this is great. We have a number of different questions, and we're going to start with one for you, Dr. Poulos. One of the audience was interested in the reaction that you received when you came back to the medical profession after your injury. Well, how did the other doctors and the medical professionals react to you?
Yeah, it was very interesting. I mean, I was surprised. I assumed, based on my limited understanding of disability at the time, I assumed that I was going to be put in a nursing home and never be able to work again. I had no idea that I would be like, that I would go home, that I would go back to work, that like this was not even on my radar. And so, it brought me to tears to know that I wasn't going to be discarded, and my fellowship program wanted me back, and they came to me the very first night of my accident and said, Pete, after you get better and everything, just know that we will be welcoming you back to work, and it doesn't matter what you can or can't do physically, we'll find a way to include you. And that meant the world to me. Um, you know, some people had weird reactions. Like one of my cardiology attendings saw me in my wheelchair and started crying and
Oh,
gave me a hug. So, you know, people just have all sorts of different reactions. But I would say, you know, it's funny because every year I meet a new class of radiology residents and a new class of fellows. And I find for the most part, people are either like a little curious about what happened, or they're much more interested in their own lives than they are about mine. And most people, I just tend to ignore it. Or if they have any sort of thoughts about it, keep them to themselves, which is just as well for me.
interesting.
And I
But
have,
let me just add one additional thing. So
yes.
my disability is very visible. I walk with a limp, I have a wheelchair, etc. And so there's really no component of like skepticism that goes along with this. And I think, you know, and I'm like a white guy. And so I think my experience is definitely not that of everyone in medicine, as we saw talking about Suchi's thing. And I think is most difficult for those with invisible disabilities, and particularly those people who have other intersectional identities.
Yeah, I appreciate you sharing that very much as someone with a psychiatric disability. My interaction with my medical providers has been interesting, for sure. So we have a question here that says, I work as a systems change advocate at an independent living center. What's a good way to support local hospitals in creating or improving inclusive medical environments? And so I know you all gave some tips, but thinking of it as someone who's outside of that system, what are some good ways to approach?
So at Stanford, one thing that we did is we created a patient family advisory council, so or called a PFAC, where we bring together disabled people from our patient community and staff from Stanford Medicine, and we meet once a month to work on these sort of thorny problems. And so, you know, we've met with people from like parking and transportation and signage and different clinics. We've met with the people who work on accessibility for the My Health application. And so we've done like accessibility audits at the medical center with walkarounds. I think it's very powerful to bring together people in the community with disabilities and those of us within the medical community or interested in disability to try and change the system from a collaborative approach. But that's just one idea.
Thank you. And I just wanted to say a reminder, if you are able to put your questions in the chat, that makes it a little more smooth for us. If you are not, we will come to the folks raising their hands, but we want to make sure that we get as many questions in, and that just helps us with this process. And I'm going to pass it to you for the next question.
Okay, what resources would you recommend to disability service professionals to become more knowledgeable about clinical accommodation needs?
Yeah, I just put a link in the chat to the Disability Resource Provider Academy that's put on by the Docs with Disabilities Initiative. They are working at creating best practices for training for resource providers to know about what the clinical environments are like, so that they can learn about those accommodations. And some of our collaborators, including Suchita, are putting together lists of accommodations and resources that would be able to be shared with them as well.
Hey, Renee, you've had your hand raised, so Gabe, can you help make sure that Renee is able to ask her question?
Yeah, one moment, please. Renee, we are going to allow you to unmute your microphone in just one moment. Okay, you can unmute your microphone and ask your question.
Thanks. I was typing away. I hope I can add a comment, something for primary care physicians that they can easily implement immediately after this presentation. I want to emphasize the importance of universal screening. When implemented universally, screenings and anticipatory guidance can ideally reduce bias in medical care. However, it's not always implemented universally. Some physicians may have the notion that people with disabilities don't need to be screened for substance use, or that people with disabilities are asexual, and then they are missed out on getting guidance on important sexual health. I've seen this in my own work. So those are really simple things that you can implement right now. And then at the higher level, when you described making changes in your practice, maybe getting motorized lifts or those things, and selling those points.
Renee, I'm so sorry to interrupt, but we're trying to reserve this for questions for the presenters. So I really appreciate your comments, and they're very, very useful, but we want to make sure we're taking the time to get our presenters' feedback on questions. So we're asking to limit it to questions so that we can get through as many as possible.
Thank you.
Yes.
Thank you.
Mm-hmm.
Okay.
And do you have another question up next?
Yeah. This is a question for Dr. Paulos. I'm an RN working at a health home in New York. We are the first and only health home for people with physical disabilities. Our core pillars are supporting our members with health, mobility, and independence. As I'm sure you know, people with physical disabilities have lower preventive screening rates, our members included. As a GI specialist, do you have any best practices for colonoscopy or colonoscopy prep for people with physical disabilities?
Sure. That seems like a very specialized question that I'd be happy to answer offline, I think. But just to say that that's great to be thinking about, and there are things that we can do, but let's do that offline.
And I think we're here to wrap up. We're about at time. I do want to point out that there were a couple of questions about resources in the chat. We will make sure that those questions, that we send you some links to those resources when we send out the materials for the training. So just wanted to let you know we're trying to get to the broadest questions that are going to benefit the most people during this limited amount of time. Anne, you want to wrap us up?
Sure. We know that many of you still have questions for our speakers, and apologize if you did not get a chance to ask them. Please feel free to contact your regional ADA center, 1-800-949-4232. Thanks, Gabe, for putting it in chat. You are going to receive an email with a link to an online session evaluation. Please complete the evaluation for today's program. We really value your input. We want to thank our speakers today for sharing their time and knowledge and all the amazing work they're doing at Stanford. And we want to thank all the audience members for attending today's session. We hope everybody has a great rest of their day. Thank you.
Thank you, everyone.
Thank you for having us.